we'll be talking more about at the upcoming AIDS meeting is thinking through what kind of information is needed to really plan to meet those future healthcare needs of individuals who are living and aging with HIV. And essentially what we thought would be really important to know is the prevalence of specific comorbidities that we know are at an increased burden in people with HIV, as well as the overall multimorbidity burden among people living with HIV who are using antiretroviral therapy. And we have modeled this for the entire United States population of persons with HIV who are using ART and connected into care. We also know people fall out of care and come back into care because life happens. So our modeling allows for that as well. Interestingly, we can project this forward, right? Because we want to look into the future to see kind of what's coming. So we use assumptions and a lot of math to essentially look into the future and say, okay, by the year 2030, which is, only in 5 years from now or so, what is the prevalence of these important comorbidities and multimorbidity, to make sure that we have the supports in place, that we know what they are and can get them in place to ensure successful care and meeting those needs of individuals who are aging with HIV. We tend to focus in on a number of both of comorbidities as well as a couple of main risk factors. So the model includes BMI, it includes smoking, and it includes hepatitis C status, because we know those are three really important risk factors for a whole slew of both mental and physical conditions. So our agents in our model have assignments to those different levels of risk factors: smoking, BMI, and hepatitis C status. And then we project whether or not they will develop different comorbid conditions. So our two mental health comorbid conditions are very common in the general population and in persons with HIV. It's anxiety and depression. So we project those. Then we have what we kind of call our middle-aged comorbidities, so more common in middle-aged. These are things like dyslipidemia, hypertension, diabetes, and stage 3 or greater chronic kidney disease. So these are some of the conditions that we start to see onset in those middle ages and in persons with HIV, sometimes a little bit younger. And then we also have cancer, end-stage liver disease, and myocardial infarction, which are, major health threats that oftentimes come a little bit later in life, and not always, but sometimes. And they also have a little bit bigger demand for management and care. And so it's that slew of risk factors and comorbidities. And, we wanted the model to really reflect the complexity of the human body. And so these comorbidities are taken into account in the agent when we're predicting additional comorbidities. For example, if there's an agent in a given year who is now assigned diabetes and depression and stage 3 or greater chronic kidney disease, their probability of a myocardial infarction or MI is going to be higher than someone who has less comorbidities that we know are related.